Welcome to VLU Grand Rounds. My name is Lowell Kabnick, and I'm honored to have Eric Hager as our speaker today, followed by Tom O'Donnell and Tom Wakefield as discussants. And we're going to start right off today, why venous leg ulcers have difficulty healing. Eric, the floor is yours.
All right, thank you very much. Let me see if I can share the screen. All right, and let me flip this over. Hopefully you can see my screen at this point.
Perfect.
Excellent. So first of all, thank you very much for allowing, this is a great honor. This is a very relevant topic, and I really do appreciate the invite to give a quick talk about this. So when we think about venous leg ulceration, we think about these patients that are the ones that come in and they are our patients for life. And this is a perfect example. This was a patient of mine in November of 2023. You see, after ablation, proper wound care, and compression, you start to see really in the better part of a month improvement in the venous leg ulcer. Then in February 2024, we were all high-fiving, we're excited about it. But unfortunately, this is now May of 2026. And as you can see, this is just a recurrent, really bad venous ulcer. And the question is why? Why do these things occur? Why are they so hard to treat? And that's really what the relevant question is today. So in short, these venous wounds, it's a heterogeneous type of wound, right? So there's wounds like this that you can safely say with a patient, hey, with good wound care, compression, and ablation, we can get this to heal. And in the setting of a patient being compliant, we can keep these healed. It's very, very different than this type of wound. So we group venous leg ulcers together, but the reality is that they're very different animals. So we see a variable physiologic and anatomic dysfunction in the skin. We see it amongst different patients. And the reality is there's a genetic component that I don't think we fully understand in the way the skin reacts toward venous hypertension and things like that. So there is definitely room to grow our knowledge base about this. Each wound requires a very individualized plan. And depending on what type of resources are available, that can vary from patient to patient. Successful healing is really predicated on patient compliance. This, I think, is one of the big problems with venous ulcers. It's not like some of the arterial patients that we see where we say, if we do X, Y, and Z and you go on your merry way, they'll get better. This requires a partnership with the patient. And even in patients with excellent treatment, the ulcer heals. The problem is recurrence rates can be really high. So there's a lot of reasons that patients develop venous leg ulcers, and there's a lot of reasons that it's a challenge to treat them. There's patient-centric factors, there's clearly anatomic and physiologic factors, and there's also what I say are provider factors, for lack of a better term, but we have patients that are being evaluated by the full spectrum of physicians, nurse practitioners, physician's assistants across really every field. Sometimes they fail to recognize the etiology of the wound, and sometimes there's lack of sufficient infrastructure to treat these wounds. So when we think of the anatomic, taking a step back, the reason that we get venous leg ulcers is really venous hypertension, and it's typically due to either valvular incompetence or outflow obstruction. In the worst case scenario, it's both, and that leads to venous hypertension. This is the most common type of leg ulcer seen in the lower extremity, with estimates as high as 80%. And VLUs occur in 2% of the population in the United States. And as we age, up to 5% of these patients will develop ulcers. It's estimated that just in the United States that 6 million people are suffering from venous leg ulcerations at any time. So what are the anatomic and physiologic causes? And again, I think it's important to understand a lot of this as we take a step back. So with venous hypertension, we get microvascular changes. So the fibrin deposition really aggregates and forms these cuffs around capillaries. This leads to an isolated areas of almost local ischemia of the skin. It impairs nutrient and oxygen transfer. There's an inflammatory cascade with leukocyte trapping, which releases of proteolytic enzymes. And you see a dramatic rise of inflammatory cytokines. And much of this is also the subject of some research that's really ongoing about how we can identify patients that are at risk for recurrence and things like that based on the inflammatory cytokines. Tissue remodeling leads to dermal fibrosis. And again, with this impaired blood supply, even a small wound, a small bump can cause problems. And then you have this biochemical imbalance. We know that the MMPs cause breakdown of the extracellular matrix. Again, this whole cascade with interleukin-3, TNF alpha, really puts these patients at risk for not only skin breakdown, but ongoing recurrent skin breakdown. When we take a look at the patient factors, so the most common patient that comes in are the obese patients, those with advanced age. Some studies would suggest over 55, others greater than 65. Certainly frailty plays a part in this. Family history of CVI, previous history of DVT, pulmonary embolism, any sort of lower extremity skeletal joint disease, and sedentary lifestyle. And unfortunately, where I live in Pittsburgh, this is literally the Pittsburgh normal. So I see these patients all the time. I'm sure a lot of us do in our practice. Another really important thing, I think that it is really underreported and I think understudied, is this idea that it changes the way that patients address the world and interact with each other and really, their ability to work. So these wounds can be extremely painful. They can be malodorous and they can be really wet wounds. So I've had patients that unfortunately have almost cleared my waiting room because their wound smells. And this is, it's a source of embarrassment. It's a source of isolation. These patients require frequent dressing changes. Often they have to go to wound care centers. So there's no doubt the quality of life for patients with VLUs, it declines. When we look at, this is a nice study actually by Dr. O'Donnell, who's on one of our discussants. It talks about the socioeconomic status and how in general, a lot of these patients, number one, they have an inability to work, but you can see the cost of, in general, of a wound is about $15,000 per patient. If they are hospitalized with cellulitis, IV antibiotics, that can jump all the way up to $35,000. And this was a study that was, almost, I would say 12 years ago at this point. But what's important is these patients a lot of times have no ability to leave their house to work. And you can see that vicious spiral. They don't have money for wound care supplies. They don't have the ability to get back and forth. They get embarrassed. They really are self-isolating. And that can lead to worsening status of their wounds. There's a number of studies that have looked at this, but there's a large range of physical and psychosocial issues that come up. So 40 to 50% of patients report anxiety and depression. In some studies I've seen with prolonged venous ulcerations, those more than 3 to 6 months, it can be as high as 80 and 90%. Oftentimes patients will delay care. And we know that one of the big barriers of venous leg ulcer healing is the chronicity of the wound. If it's been there for greater than 3 months, oftentimes it's harder to heal. So patients failing to seek early care really can affect their long-term outcomes. These patients oftentimes have reduced mobility. Their forced lifestyle changes cause social isolation, embarrassment, and again, feelings of helplessness. Feelings that no matter what I do, it doesn't get better. Whoa. So for the healthcare providers that care for these patients, it's really crucial. As important as treating the physical wound and the underlying axial reflux is also understanding the psychological impact that these patients really are going through. And in any way of being able to help that can really help improve the healing of these. So now we talk about the provider factors. Why do these things fail? So we know aggressive ablation of refluxing axial veins, central venous stenting, reduced venous hypertension. We have a full, there are so many studies out there showing that with planometric analysis, the wounds heal faster, they recur less frequently, and there really is a lot of different ways of doing this. We know that the isolated saphenous reflux can be treated with thermal, non-thermal techniques. There's dedicated venous stents now for their outflow obstruction, and again, these work really well. But again, we love, as surgeons, I love to say I ablated it, my job is done. But the problem is these VLUs really require this multifaceted approach. So you need to have the infrastructure for multiple follow-ups. You need, ideally, advanced wound care centers. You have home health care. We use nutritionists. I find that to be really helpful just for wound healing. And we also have to have access to a hospital system. Sometimes they require either debridement in the OR or admission for IV antibiotics and cellulitis. So you really do need a full spectrum and a full team. Wound care is incredibly important. We know that washing, getting rid of the biofilms that are on these wounds is incredibly important. Debridement has been recommended of all non-viable tissue in an effort to reduce the kind of that transition to a chronic wound. There's been a lot of meta-analysis that have shown that even with local debridement, that there's a reduction, an area reduction of the wound care, of the wound size. So again, this just shows that you really need to be aggressive. It's not just ablate and forget. You have to be really willing to do this. Sometimes it's short enzyme assisted, sometimes it's mechanical. And one of the barriers here is that some phlebologists just are not comfortable with this. We can ablate, and there's a lot of proceduralists that ablate wounds or ablate veins, but they're not able to do the extended kind of treatment algorithm. And that's really what we're looking for. When we talk about compression, probably the most important aspect of ulcer treatment. It is, number one, is it has a lot of different functions. It reduces ambulatory venous pressure. It decreases inflammatory cytokines. It basically is reducing a lot of the inflammation in these wounds. It's been shown to heal wounds and prevent them from recurring. The problem with it is, again, it is extremely labor intensive. It's challenging for patients and providers. A lot of us physicians don't have the ability to get patients into our clinic for daily wound changing or every other day. So we rely on other providers. So in summary, so VLUs can heal and they can stay healed, but there are significant barriers and challenges throughout our practice at large. So effective healing requires a good clinical team with an understanding of the pathophysiology of venous ulceration. I think it's important to have advanced wound care to wound care centers, home health care support, nutritional support, and surgical intervention is always when it's needed. Patient compliance, lifestyle changes, weight loss, nutrition, exercise are critically important. Patient buy-in for their own care with ongoing compression, early access to physicians should things not be improving or plateau. You need to have good social support networks. And again, compression compliance is mandatory. And then I would say close clinical follow-up. Again, it's not like treating an arterial patient where if you treat them once, you may not need to see them again for a year or two. Make sure that if things are recurring, good axial reflux studies, reassessing the wounds, things like that. So I do think it's important for close clinical follow-up in our clinics as well. And I believe that is a quick summary, some references, and I do thank you for your time and for listening.
Thank you, Eric. That was brilliant. We're going to go right to Tom O'Donnell as a discussant, followed by Tom Wakefield.
Thank you, Lowell and Dr. Kanata, for including me in this excellent case presentation. And it's only fitting that I want to express my gratitude to Eric for his participation as one of the 52 experts, along with Anil Hingarani, who's on this call, in the revision of the 2014 SVS-AVF Clinical Practice Guidelines for Venous Leg Ulcer. Worldwide, the earlier guideline, the 2014 one, was the most cited VLU-specific guideline and is one of the most cited SVS-AVF guidelines overall. Eric is involved in this extensive revision along with members from 6 sponsoring societies besides the AVF and SVS. The revision process is in the final stretch, as our 2 participants know, and we hope to have it available by the summer. Personally, for well over 50 years, I've been interested in why leg ulcers either fail to heal or are delayed in healing. In 1976, we published in Lancet a 5-year follow-up observational study of patients undergoing superficial venous surgery, including open subfascial ligation of incompetent perforating veins at St. Thomas's Hospital in London. And that's very relevant to the current patient who obviously has had recurrence. All patients underwent preoperative venograms to define the status of their deep venous system. The number 1 risk factor against maintenance of healing was infrainguinal, not outflow obstruction, post-thrombotic venous disease. And this theme carries through over the next 50 years. To identify some of the problems and modify how you treat patients, risk factor analysis is crucial, not only to interventions in patients like the one presented, but also to give them a realistic outlook on what can be achieved. risk stratification permits tailored therapy and is associated with better outcomes. It identifies high-risk patients for delayed or non-healing, the so-called recalcitrant ulcer. A critical component of this process distinguishes between factors that can be modified and those that cannot. Risk factors for non-healing of leg ulcers, such as large wounds, 5 to 10 centimeters, long duration in excess of 6 months, were identified by both David Margolis and Bill Marson independently over 25 years ago. A systematic review of 27 studies performed over a decade ago by an Australian group confirmed these earlier findings, as well as Eric mentioned, emphasizing the problem of decreased mobility and ankle range of motion, as well as poor nutrition and, like me, increased age. One of the problems with these previous studies is they looked at non-healing over a shorter time period, for approximately 6 months or less. In addition, the protocol for treatment among these patients was variable. We conducted a study from our venous leg ulcer registry of 69 C6 patients with open ulcers undergoing treatment following the SVS AVF guidelines. For over a year, 30% of these patients failed to heal. When we looked at the multiple risk factors for both patient-related and disease-related components and demonstrated in multivariate analysis that deep venous disease, history of DVT, very relevant to what Eric has discussed, depression, and non-white ethnicity were very highly significant factors. Also, something that Eric has devoted his time to, the finding of an incompetent perforator near the ulcer was a significant beneficial effect for therapy. The advantage, as you know, of a multivariate analysis is that it removes the potential for confounding and identifies true independent risk factors for non-healing. The marked differences in venous leg ulcer healing between the two healed cohorts is best exemplified by the 84% presence of deep venous disease in the non-healed versus the 48% healed. Lowell encouraged me to ask a query, and I asked Eric, given your interest in perforating vein disease, how do you sequence this treatment? And more importantly, with the randomized controlled trials that are available, EVER and EVRA, neither of which treated the incompetent perforating veins, coupled with the fact that the Dutch SEPS trial showed no difference between perforating vein treatment and just compression alone. How do you rationalize that?
So these are excellent questions. And I do think that one of the hot topics I think that we've discussed and people are very outspoken about it is the order of treatment of the either axial reflux, outflow, or perforating veins. And I think almost everybody that I've talked to is either in one camp or another and not really willing to move to the other. And what I have found, so my algorithm essentially is, as I said, I think in the first or second slide, one of the most important things that we do is we cater our treatment algorithm to the patient. So patients that come in with very large chronic wounds, wet wounds, things like that, I tend to be very aggressive. Certainly if there's an outflow issue, I will treat that first and foremost. You know, I think venous stenting and reduction of outflow is incredibly important in conjunction with the axial ablation. So I will be very aggressive with that. And the question always comes in, well, what about the patient that has a smaller venous wound or a little less chronic? Can you get away? And some of these patients do have a history of iliofemoral DVT. I will ablate the axial veins first, and I'm very aggressive about perforating veins near the ulceration. I think filling the subulcer plexus is really one of the most important things we can do. And so a lot of what my target is I enjoy radio frequency ablation of or laser ablation of the perforating veins. I will then backfill that subulcer plexus. So I think it is our understanding of the pathophysiology of perforating vein disease has evolved. And I think that some of the trials that we have seen in the past probably didn't, ablating a vein maybe near an ulcer, but not filling the subulcer plexus at the same time. I think our treatment has evolved. So I do think that there's room for further studies regarding this. But
Thank you, Eric. I'm gonna, because I want Tom to weigh in here, Tom Wakefield, and then I have a burden of questions for you, but I don't think we're gonna make it. So let's keep our answers short if we can. Thank you.
So thank you very much for the presentation and the opportunity here. I would just sort of say that when I look at the history of how our field has evolved over the last 10, 15, 20 years, these are the things that for treatment of venous ulcers, I think are the most important things we can think about. Number one is a much better understanding of the pathophysiology. And I think some of the things that Joe Raffetto is doing, looking at the effect of the glycocalyx, the effect of iron in the tissues, MMPs, and nitrogen products are all important parts of the pathophysiology that we truly don't understand how they impact. And as we understand more, I think we'll have some directed therapies in addition to what we've talked about to help. Secondly, use of venotonics. We really didn't talk about that. Certainly MPFF has been found to help speed ulcer healing. It does decrease edema, decreases pain. What we don't know, I think, is whether or not using venotonics once the ulcer heals can actually help prevent recurrence. And so that's an area that I think I'd like to hear more about in the next few years. One of the changes has been trying to do a complete treatment of both the superficial system, the perforator system, and outflow. And whether you do it all at once or you do it in staged fashion, one thing clearly is that you really have to treat all the disease as best you can. I am also been excited, although this really occurred after I retired, the use of sclerotherapy in foam underneath the venous ulcer bed seems to have a more and more significant role in healing. And finally, I'm interested in the new non-elastic compression garment devices that are available. And one of the problems has always been trying to get appropriate compression. Non-elastic compression, I believe, is always better than elastic compression. But now we have some devices that allow patients to be ambulatory and to function with non-elastic compression devices. And I think that will have a role to play in trying to decrease recurrence. So these are some of the changes that I've seen over the last number of years.
Thank you, Tom. Eric, what's our experience going to be with obesity and GLP-1? And should we take your average patient that you pointed out, put them on a diet before, as well as doing all the others? Do you feel that that's just almost as important as everything that we've mentioned here?
100% I do. So there was a study that was was presented at the American Venous Forum looking at venous leg ulcer incidence, healing rate, and GLP-1s. And it was relatively small and certainly not enough to draw any major conclusions from. But I will tell you that it seems to me that weight loss and these GLP-1s going hand in hand, I think is going to be a game changer for the way that we treat these patients. I've seen patients in my clinic that I've now said, this is a clear indication to start this medication, and I think it really will help.
Thank you. Tom, many years ago, we were in Hawaii, and one of the ideas there was to decrease ulcers by 50%. Do you think we've reached that, and why haven't we?
Well, sorry, go ahead, Tom Wakefield.
I'll just make one comment that, Tom, you'll be able to answer this in much more detail. But I think we have not. And the reason I think we have not is because we really don't understand fully the pathophysiology. And as we understand more of the pathophysiology, I think we'll be able to treat the disease. Secondly, we really can't predict well enough yet who is going to go on and have a recurrence who once they're healed. And we don't have a good way to predict who actually is going to heal, despite the fact that we treat with all the modalities that we have. So those are areas I think will allow us to get to that point, but we're certainly not at that point now.
I would just say, what's the evidence that we haven't achieved this? And if you look at, you need an epidemiologic study to sort of compare before and after. There's only one study in the US by Monica Levitsky in the county and around the Mayo Clinic, which looked at this, and actually the incidence of venous ulcer increased in that population, despite being pretty close to a world-renowned center. By contrast, in Sweden, they demonstrated with the institution of guideline-like approaches that they could reduce the incidence of ulcers. So the jury's out, but we need an epidemiologic study to sort of assess that. But we don't have that now, with all the commentary that totally agree with that Tom made.
Eric, what about starting with the subulcer venous plexus? We always look at trying to reduce venous hypertension either by truncal ablation, perforators, or iliofemoral outflow obstruction. What about going to the root?
First, before ablation of the other? Is that what you're asking?
Yes.
Yeah, I mean, I think that's a provocative, and I've certainly done that before. I think it's a provocative approach. I feel like it still doesn't address the underlying pathophysiology in some ways. I do think if you have significant axial reflux, it's better to disrupt that column of blood and the weight that it exerts and all the kind of the cascading effects, and then, or even concomitantly, ablate at the same time and foam the subulcer plexus. But it does feel like I'm leaving some stones unturned if I just do the subulcer plexus.
I agree, and we found out with truncal ablation the idea of not treating perforators first, because sometimes those change, and we really don't know a lot of the pathophysiology of perforators as well as the subulcer venous plexus. So all of that's all related, and it'd be interesting for our young scholars to help us out as we go forward. Before I end this meeting, is there any final comments by Eric, Tom, or Tom?
Yeah, I'd like to make one. I was glad to see Eric emphasize it in his flow diagram that leg patient had a very swollen leg, and you did reduce venous hypertension. It just emphasizes the role of treating the lymphatics, which helps rid the tissue of toxic metabolites. Indeed, studies have shown that despite reducing venous hypertension, about a third of patients will have persistent edema. So don't forget the lymphatics.
Very important.
And Tom, I would just add on to that, swelling is inflammation. So
Right.
when you see a patient who has swelling, they have underlying inflammation, and you have to remember that.
Well, thank you, everybody. Next week, we're going to continue on with compression, oxygen, and humidification improves venous wound healing and reduces venous ulcer recurrence. Joanne Lohr, who's done a study, will be the main speaker, and Neil Hingarani will be discussant, and Thomas Maldonado will also be a discussant. So we look forward to seeing you next week, and thank you, Eric. Thank you, Tom, for this enlightening conversation. Thank you again.
Thank you.
Thank you very much. Thank you. Great job, Eric.
Excellent. Thank you guys again for that. I mean, it was wonderful. I appreciate it. I enjoyed giving and quoting studies that the discussants have done in the past.
Thanks, Eric.
My pleasure.